I would like to introduce our first session of the day, Artificial Intelligence in Nephrology, Promises and Pitfalls. Artificial intelligence is no longer just a buzzword. It's reshaping how doctors think about diagnosis, treatment planning, and patient care across medicine. In nephrology, AI tools have the potential to predict kidney disease progression earlier, optimize dialysis prescriptions, improve transplant matching, and even reduce disparities by identifying at-risk patients who may otherwise be overlooked. But with these opportunities come important questions. How do we ensure that AI models are accurate, unbiased, and ethical? How do we protect patient privacy while using large data sets to train these tools? And what role must patients, clinicians, and regulators play in shaping how AI is implemented in kidney care? Well, AAKP has played a significant role on this issue over the past 5 years, including through our involvement in the FDA's Patient Engagement Advisory Committee on New Medical Devices. Today, we're fortunate to have two outstanding leaders who will help us explore both the promise and the limitations of the rapidly evolving technology. First, we'll hear from Dr. Mike Hoffman, Director of the Office of GastroRneal, OB-GYN, OB-GYN, General Hospital and Urology Devices at the Food and Drug Administration Center for Devices and Radiological Health. Dr. Hoffman has been with the FDA's CDRH program since 2007, overseeing device policy and evaluation across multiple specialties. From 2020 to 2024, he led the agency's medical device shortages efforts and helped develop tools and policies to safeguard patient access. He holds degrees in electrical and biomedical engineering. And then next we'll hear from Dr. Amy Waterman, Division Chief for Patient Engagement and Diversity at the J.C. Walter Transplant Center at the Houston Methodist Hospital. A health services researcher and social psychologist, she has led over $30 million in federally funded research projects to improve transplant education, reduce disparities, and expand access to care. Her award-winning tools and educational programs are used in thousands of clinics across the United States and in Canada, and she has helped shape national policy through her work with UNOS, the American Society of Transplantation, and the Center for Medicare and Medicaid Services. Although Dr. Hoffman wasn't able to join us in person, we were pleased to connect with him last week to capture his presentation. So please turn your attention to the screens for Dr. Hoffman's presentation.
Thank you, Ed and AAKP. I sincerely appreciate the opportunity to speak with you all today. I really wish I could be there in person. And hopefully I can be there next time when that happens. So my name is Mike Hoffman. I'm from the FDA, specifically in CDRH, which is the Center for Devices and Radiological Health within the Office of Product Evaluation and Quality. And I am the director of OHT3, which is the Office of GastroRneal, OB-GYN, General Hospital, and Urology Devices. I'm here today to give you some insight on FDA's approach to digital health and some perspectives on AI within CDRH. First, I want to note CDRH's vision, which is truly focused on patients. Patients in the U.S. have access to high-quality, safe, and effective medical devices of public health importance, first in the world. That is the vision for CDRH. And again, it's to make sure that patients have access to devices that are safe, that they do what they say they claim to do, and that that patients can actually receive those technologies before or at the same time as they would in other countries. But first, we're going to start with some basics. So what is a device? A device is a product that is intended for use in the diagnosis, cure, mitigation, treatment, or prevention of disease or other conditions and is intended to affect the structure or function of the body. But it doesn't do so through chemical means. If it does it through a chemical means, then it's a drug. So by this definition, a software or software function even can be regulated as a device by FDA. So based on that classification, FDA classifies devices by risks and the controls needed to mitigate or address those risks. Our highest risk devices are class 3 devices, such as a pacemaker. And these are typically devices that are life-saving or life-sustaining, and for which we can't really address the risks without the highest levels of control, including full clinical studies for each individual device. These devices are assessed through a pre-market approval, or PMA, before they are allowed to be marketed. Our medium risk devices are under Class 2 and represent the majority of devices that we regulate. Some ventilators and a lot of other surgical tools fall under these categories. A very wide range of products fall under these. And we can address the risks associated with these devices through controls such as standards testing like electrical safety, biocompatibility, and in some cases even additional clinical information. While a PMA for a Class 3 device must be assessed independent with having independent data to support its safe and effective use, a Class 2 device is assessed basically through a comparison to something that's already legally on the market. They contain a considerable amount of data for various amounts of testing to show that they are equivalent to that marketed device. And again, that can be through standards testing, animal testing, and sometimes even clinical testing depending on the device. And this comparison is submitted through a pre-market notification, also called a 510K, which must be cleared by the FDA before the device can be marketed. There are some devices that are novel that can be assessed and may not necessarily have the same risks as a Class 3 device. And these come in through what is called our de novo process, which allows a novel device to come in and ultimately can be regulated and assessed to be Class 2. But we have to do a considerable amount of testing or assessment of testing because it is a novel product, and we have to determine whether or not the controls necessary to address the risk of the product are sufficient to make it a Class 2 product versus needing a Class 3 designation and needing a PMA. Lastly, our lowest risk products, or our Class 1 devices, are really only need what are referred to as general controls to assure that the device is safe and effective. Now, general controls include things like labeling, good manufacturing practices, and adverse event reporting or medical device reporting. And these can be marketed without a submission to FDA or approval. So these can be marketed straight away if they fall under that class. Though not mentioned on this slide, we not only work on devices before they go to market, but we also monitor them while they are on the market through medical device reports, such as adverse event reporting. And we also address issues through regulatory actions like recalls and inspections. Now, with those basics, let's start shifting to the main topic, digital health and subsequently AI/ML. Digital health tech has been growing exponentially as people identify new and improved uses for them in the healthcare sector. Some are simply measuring and providing information to users. Others are monitoring more specific technical information that are used by doctors and other healthcare providers. And some are actually assisting doctors and healthcare providers in the analysis of data as they look to make decisions. All of these are rapidly improving, and they are also critical to help broaden the reach of healthcare and help move healthcare to even a home setting, which will be critical to expand the reach for folks who may not be able to readily get to a doctor or a hospital in some cases, or to just be able to reach doctors more easily if they are far from where their primary care or specialist may be. And just as a note, to date, we've cleared or approved over 1,200 AI or ML enabled devices. I do want to clarify a few terms around AI and ML. So AI, or artificial intelligence, it's defined here. It really has to do with the science, stats, and engineering that basically uses algorithms or models to perform tasks, but actually exhibit behaviors like learning and decision making, and even making predictions. And that aspect is something that becomes critical when we have a lot of, say, data-driven science in healthcare, where there's a bunch of information and people are looking for assistance in how to make decisions and how to interpret data. Machine learning is a subset of AI that allows computer algorithms to learn through data without being explicitly programmed to perform a task. And then an AI ML enabled device is a device that's basically using machine learning to achieve its intended use. So using those definitions, there are a wide variety of uses for AI ML in medical devices, ranging from providing information for humans to make decisions, for all the healthcare providers and to make those decisions, or even users to make some of those decisions, to, at the other far end of the spectrum, AI making the decisions and acting autonomously. We're not at that stage yet, but there's a wide range in between those two extremes, and that provides different levels of assistance and information to patients and caregivers. Considering that wide range of uses, how do we think about AI in medical devices? And it still really boils down to the same things we consider for all of our products. Intended use, how it's being used and who it's being used for. the benefits of the product and the risks of those products. And as noted on the last slide, there is a wide variety of uses and applications, each with different benefits and risks. And for a device to be authorized, the benefits need to outweigh the risks for that intended use population. Adding in AI doesn't change that. However, the risks and benefits can differ based on the different uses of the AI ML, as noted in the last slide. Kind of with that notion, a big question comes up is how do we regulate a specific software? So we often need to help manufacturers and users assess how a specific software will be regulated. Some of them will be deemed not a device because it won't meet the definition of what we have for a medical device. Some will be under what we refer to as enforcement discretion, which allows them to be marketed under very specific conditions without a marketing submission. And typically these are cases where the risk is deemed to be sufficiently low that it's not necessarily a concern, although it still meets the definition of a device. And this really allows us to focus our energy on where we need to provide very active oversight because of the risk associated with the device and the AI/ML specifically embedded in it. Where some of this distinction came from actually dates back to 2016, when we had kind of more of the start of some of our digital health regulation, or at least changes to it. And that came from our 21st Century Cures Act, where we noted, which types of software or software functions were excluded from the definition of a medical device, meaning they would not be regulated by FDA, because there was necessarily not needed to be a reason for us to regulate a large portion of software that a lot of hospitals and other people use, because the risk associated with it is outside of our purview, and the risk is not necessarily something that we were as concerned about. So some of those are just a lot of the administrative software that's used in hospitals and facilities, ones that generally encourage healthy lifestyles, and it's not really referencing a disease or a condition. You think of a lot of apps that are on, various smartwatches and even smartphones. There are a host of those that have health information, but they're not necessarily referencing specific diseases or conditions. Things that are used for electronic patient records, things that are simply just storing and transferring results, transferring information. And then additionally, some that are intended for clinical decision support. So helping doctors make certain types of decisions. So this is a busy slide, and I'm not going to go over each of these items. But what I mainly wanted to convey is over the last several years, there's been a lot and ever increasing activity on our side to try and guide and in some cases appropriately regulate development of digital health and of AI/ML. So there are a host of things on this. So there's a variety of different types of activities, whether it is publishing a medical device list associated that includes AI/ML. I think you can also note there's numerous guidances and other aspects that we've been focusing on to try and provide different types of information to the public and to developers so they can be aware of what FDA is thinking on AI/ML, especially as it is rapidly evolving. And our goal is to really promote responsible digital health innovation by ensuring that there's predictability in the process while still maintaining patient safety. And one of the reasons we've been successful in this to date is because we work collaboratively with tech experts and other stakeholders to advance our policies for digital health and AI. And in fact, the benefits we've seen of interacting with these experts led us to establish a digital health advisory committee. We held our first meeting last year on the topic of devices enabled with generative AI, and this allowed us to hear from experts in the space so that we are well positioned to understand the benefits and risks of these technologies as we start to see submissions for them as they leverage generative AI. Like I said, I won't go into all of these, but I will highlight a few of these on subsequent slides. So one of the key efforts was to develop an action plan for AI/ML. So it was aimed to be a holistic, patient-centered approach and helped bring in collaboration with other stakeholders. And, as you can see, there are a number of aims, and one of those aims is really, again, fostering that patient-centered approach to help better position ourselves for better advancement of AI/ML so that we are focusing on patients and bringing those viewpoints and items and things of importance that patients find helpful into the fold as we are, adapting to this evolving field. One of the other efforts was to list all of our AI/ML enabled devices. This is a snapshot. It's a public list. There's a link given here. To date, we've authorized more than 1,200 such devices, and it's across a wide variety of medical specialties. So This is something that's available to everyone. I think this was last updated in May. I can't say I recall how often it's updated, but I know it is periodically every few months they do populate that full list. And it is a way that you can go check and look for different devices, different manufacturers, that you can see if there is AI, ML included in a device, if there is something that you are looking for. So briefly, I will give a few examples from that list that we have. And some of these go back to 2018, some of them are a little bit sooner, but just to give an idea, so we have some clinical decision support for providers to help identify a potential stroke in patients. We have ones to help detect certain eye issues related to diabetes. And there's a host that are associated with various types of imaging. So here we have ultrasound software that uses AI to help guide users through the ultrasound process. And actually, there is a lot of AI. Probably most of our AI is currently being used to assess imaging analysis. That's where a bulk of it started, and that's still where we have the vast majority of it. And a lot of that has to do with, one of the benefits of AI and machine learning is that it can help detect patterns and help, in many of these cases, help point out areas where physicians can focus some energy to see, particular lesions or particular cases or areas of interest, not necessarily limiting what a doctor can look at, but helping identify pre-screening to see if there's some additional things that they should focus on. So here we have a couple examples of helping to identify prostate cancer, as well as signs of colon cancer. And so lastly, as an example, we have a device that was authorized last year, which had to do with helping identify patients at risk, having sepsis or at risk of developing sepsis. And so this was basically used to pull using patient health information, and it provides information to the users, namely the healthcare providers, on the information that it's assessing and which areas of the healthcare information actually raise concern potentially for sepsis risk, and helps identify a score associated with that so that healthcare providers can assess whether or not they should be looking at sepsis more carefully for a given patient or not. And again, they'll be looking at other pieces of information too, but this was a device used to kind of aggregate a lot of information to provide one opinion that a doctor could use and utilize to help assess. With these various efforts, what does that mean for folks? So for developers, it provides questions to address in terms of when they're looking to develop a device, whether it's the benefits, the risks, including what has been demonstrated in terms of benefits and risks. But more also for users, we aim for transparency in the labeling. That's one of the things that we are very passionate about, is trying to make sure that users have the appropriate information so that they can make decisions and understand kind of how the device is working and what restrictions or cautions they should be using when or have in mind when using this device. So we have devices that are assessed in their clinically relevant scenarios. We try and make sure that as we're assessing these products, they are in the obviously relevant populations and relevant scenarios that they are going to be used, so that it's most appropriately mapping to how the device will be used in real life. And then it really, all of this information helps inform users if a device is right for them, or if in the case of a healthcare provider, right for the patients. And so that's kind of one of the key things that we were trying to make sure that people have awareness of and have information on. Again, I'm not going to go through all of the information here. One of the key ways that we communicate policy is through our public guidance documents. And these are all examples of those. And these are all related in some way to digital health and AI. We've published several in the last several years. And I will say that it takes a while to publish guidance documents. So the sheer number that we have associated with this topic is telling in terms of how much effort is being put into this area. And one thing to note is these guidance documents almost always, maybe with very few exceptions, go out in draft, allowing us to collect comments from all stakeholders as we consider these policy changes. And those stakeholders can be manufacturers, they can be patient groups, they can be healthcare providers. We do get quite a bit of comments back from them, and they are all very helpful. We review all of those comments. And we factor those into when we make revisions to the guidance to finalize it, or in some cases, even go back out and draft if there is significant comments that warrant us changing course. So one example is a draft guidance on AI-enabled software functions, specifically providing guidance on lifecycle management. So the purpose of this draft guidance is really to provide proposed recommendations on the pre-market expectations for AI-enabled devices. And these recommendations were developed by leveraging the years of experience we have regulating and authorizing these devices. Our development involved a cross-office working group where we analyzed common deficiencies and review practices to align on some proposed recommendations here to help increase predictability for all manufacturers of AI-enabled devices. I'll also note that this guidance includes a TPLC approach and provides considerations and recommendations across the life cycle from the development to post-market. And I will say, so TPLC is what we refer to as the total product life cycle. So that means that we are not just responsible for the device until it gets to market. We're responsible while it's being developed, providing information back to manufacturers, working with them, working on the assessment of the device while it's with us before it is marketed, but then also monitoring its safety and performance after it's reached the market throughout its life cycle. One last effort noted is that we have a digital health policy navigator, which is a resource for stakeholders to help themselves assess whether a function is subject to FDA's active focus or not. And I will say that it is actually in plain language so that most folks can actually have a better understanding of how we're approaching software regulation in general, and hopefully doesn't have as much jargon as it could, especially considering some of our policy and legal folks would probably put in. And lastly, one of the key things is that we also welcome engagement with other groups and stakeholders, such as AAKP. We look for feedback through a variety of mechanisms so that we can inform some of our decisions going forward. Not necessarily specific decisions, but on broader issues, such as this one. We have pre-submission meetings. In a lot of those cases, we can have discussions with specific groups. We often use those to discuss a specific product that a developer is creating, and sometimes they have people come and provide, I would say, testimony or help illustrate the need for that product. We have public workshops. We have other education and training. And then, as noted earlier, we have comments on our guidance documents. In summary, AI-enabled devices have many of the same types of regulatory questions as other medical devices, such as intended use, benefits, risks, some unique considerations. And these devices are having an increasingly important impact across all medical disciplines, including gastroenterology, including nephrology, and they have the potential to significantly improve the care patients receive. FDA welcomes your engagement and collaboration. We provide resources on digital health technologies, including those enabled by AI/ML. The best source to answer questions specifically to digital health is with actually our digital health group. The contact information for that group is given here. And with that, I'm happy to answer any questions and hear any feedback you all may have for us at CDRH.
Sure thing. Well, thank you. And we greatly appreciate Dr. Hoffman's presentation and the terrific work of the FDA CDRH. We didn't let him off too easily, though. While we had him, we took the opportunity to pose a few questions. So I'll read those questions to you, and then we'll go to Dr. Hoffman's response. Our first question was, how can patients be sure that the new AI tools in kidney care are tested fairly so they don't carry forward human bias?
So that's a great question.
Thank you.
I think there are a few ways that patients can do that. So we have a public list, as noted earlier, of AI-enabled devices, and that is one list to know which devices we've fully reviewed. And I think, as noted, there are some devices which are allowed to market that we wouldn't necessarily review because they're deemed lower risk. But for that list that is given, those are the ones we have actively reviewed. And so that's one way. But I think, and kind of with that, we are applying the same review standards to these devices that we use for others. And then we are also taking into account the, say, risks and benefits specifically associated with the AI portion as well. So those are kind of the main reasons that I would say that we are focusing on those. And obviously taking into consideration, how AI is being used in that specific scenario. What are the risks associated with it? What are the benefits associated with it? That factors into the review. And I think that's probably the best way we're addressing it. We're providing all that information in the labeling, any kind of precautions, any limitations that we have related to the use. That's where we're trying to be transparent to patients as best we can.
Thank you. So after an AI tool is approved for kidney care and starts being used with patients, what kind of follow-up data does the FDA expect to see? For instance, how well it works in real life, whether it treats all groups fairly, and how safe it is from computer hacks. And if something is reportedly have gone wrong, how do we report that to the FDA or whomever?
So maybe I'll start with the second part, because in general, this is something that we do for all of our products, not just our AI-enabled products. We have and depend on monitoring safety issues, and these are reported by firms, by users, by facilities, by patients. We have programs to collect information, basically what's called our medical device reporting, or MDRs, and a lot of this is providing just adverse events reporting, but it's a way for us to get feedback on any potential safety signal or performance issues.
Great.
Looking at the first part, so for AI devices, one of the things that they include in submissions to us is how they are going to continuously assess performance, specifically so that it still falls under their performance specifications. And this becomes more of an issue as AI algorithms develop over time, because they're continuously getting information as they're continuously used. So that's one of the aspects that we've focused on, as well as part of the review, is what is their plan for continually assessing performance to make sure it still falls under specifications. We don't necessarily see that information. We can see that information during inspections, for example. In terms of whether it's treating all groups fairly, we have, when we receive reports, and sometimes this is through journals or other, types of medical reporting and medical literature, we do look for signals if there are some cases where there might be different groups that are having different types of diagnoses, or if we see that there is starting to be a delineation between groups. And sometimes manufacturers will also start to highlight that, particularly if they start seeing that there's an improved performance in a specific subgroup. That's something that a lot of times manufacturers will hone in on as well. But if we get that information, those are ones that we have in the past, reached out when we become aware of them, reach out to manufacturers to make sure that we are being clear and that they can address concerns associated with them, so that, again, that it's transparent to users, particularly if there's a decrease in performance for a specific subset of the population that it's intended for. And if it becomes the case where a device is no longer, or not necessarily meeting specification for the whole intended use population, then we have a discussion with the firm to see how to remedy that situation. And I think the other piece too, how to keep it safe from computer hacks. So one of the key things that we do have for pretty much all of our devices now, particularly with our software devices, not just AI devices, is we have a host of cybersecurity testing and standards that they have to meet. That has ramped up considerably over the last decade, and is continuing to be a primary source of our, or not a source, but focus of our review. Thank you.
Great. And one final question. How is the FDA coordinating with CMS and professional societies on coverage and standards so safety and efficacy AI actually reaches patients? And how are or can patient organizations like the AAKP play a role in that as the ultimate end user of this technology?
So that's a great question. And there are a couple pieces in there, so I'm going to kind of take them a bit at a time. So one thing, just to clarify, FDA doesn't provide coverage decisions. I think there are some people who confuse what FDA and CMS, what they do. So even though we don't provide coverage decisions, the coverage groups, including CMS, as well as some other payers, can utilize information from FDA to help inform their coverage decisions. But one of the things we have done is encourage developers to work with CMS and other payers to kind of fold in their feedback and their thoughts when they're starting to do a clinical study for us. And we have had a program that helps basically invite people like third-party payers and potentially even CMS to come meet with us when manufacturers are coming to meet with us regarding a study that they're going to be doing. And in those cases, it's for the benefit of the manufacturer so that when they do a clinical study that meets our needs, it can also meet the needs of CMS and potentially other payers. Because the standards for CMS and typically payers are different than what we have for FDA. Because in our case, it's whether a device is safe and effective, whereas for CMS and other payers, a lot of it has to do with whether or not it's necessary. And so there are other pieces that they have to consider that we don't. So in several cases, they may ask for additional information to be collected, which makes sense for manufacturers. If they're already going through the effort of a study, why not add in a few other assessments too? So that's one way we have worked with CMS and payers. Regarding standards, we work a lot with standard societies to help identify what are some issues, what are some gaps, to help develop technical standards for a variety of devices, so that there's additional information kind of in parallel with our guidance documents, which are some technical and some policy. But our standards group focus pretty much on the technical aspects, and it's a way for us to work directly with stakeholders, manufacturers, and academia as well, to help develop what are the appropriate standards for given device areas and maybe even subsets of a specific device type, to get that information to patients, to get that to developers so they can meet those standards. And there's usually a lot of back and forth on what the appropriate standards are. So we have a lot of very healthy discussions on the appropriate standards. But I think the key question also is, how do, I'll say, patient organizations or AAKP play a role in that? So one of the best ways that patient groups play a role is they can provide insight that not everybody else can, because one of the things that we focus on at FDA a lot is, again, looking at the patient at the center of everything. And one of the big pieces of that is what is important to patients, what benefits are important to patients, what aspects of a device are challenging, provide risks that maybe patients wouldn't be willing to accept even for a given amount of benefit. So there's a bunch of information that we get from patients or from patients to help inform our decisions, because then we can make a better assessment for a given device on whether the benefits outweigh the risks. Because if we have insight to what benefits patients consider to be worth the risk, that really helps inform our decision making and gives us confidence one way or the other. Now, in terms of how people can do that, I think, as noted on the previous one of the slides, noting, say, patient engagement and how we engage with people through guidance documents, through public meetings, through pre-submissions, through education and training, and even just interactions like this, that helps us get an idea or more information on what is important to patients. And I think that really is the key piece that we like to hear from patients.
Excellent. Well, we thank Dr. Hoffman for his time and his insight. And now moving on to our next presenter, we're pleased to welcome Dr. Amy Waterman. Doc, the floor is yours.
All right. Good morning, everyone. I am here both in my role as the Director of Patient Engagement at Houston Methodist, and also as a member of an important steering committee that I think could benefit all of you, and I hope reassure you as we move into this AI age where AI is merging with some of the healthcare that you've been receiving from human beings. So as a member of this steering committee, this is the American Society of Nephrology Steering Committee that is a partnership for responsible AI use. And I love coming after the previous speaker because he's basically showing us first, federally, all the regulations that are happening. Right? So if you kind of take the big takeaway from what he said is there are many, many different types of things happening federally that anyone using AI has to follow. Now, the second level is now that we are following those, how can this improve your health? How can this improve healthcare in general, right? Like that's how it touches my life as a healthcare professional and you as kidney patients. So I want you to know this group is looking at that. And as a member of ASN, I'm a member as a person working in a hospital, but also look at all of these different types of people with expertise in nephrology, in innovation in nephrology, and people with kidney diseases are critical in terms of our family. So I just want you to know we're proud to be here representing. And I want to kind of show you a little bit about, I want to make this real. Okay, so we're talking about AI, and I'm about to go into AI, but let's just talk about making care better. So I live in Texas, I'm in Houston, and in Texas we have a recommendation that says the Center for Disease Control says that we're second in terms of deaths due to kidney disease, and the governor of Texas wants us to do a series of things. They brought a task force together and they said, okay, we need more targeted screening interventions. We need more statewide population health models that do equitable access in two things. So if our patients in Texas were doing okay, they would get medications that show promise for preserving kidney function. Wouldn't it be great to get the drugs to people so that their own kidneys wouldn't fail faster? Right? That's what we all want. We don't want you to have to move into transplant. But then if kidneys are failing, we want you to have access to transplant equally across our entire state. And if we could generalize, I just spoke this because we're in Texas, but this is true everywhere. So now, how could AI and machine learning help? Okay, so this individual gave us very, very specific information about what AI is. And I'm a patient engagement specialist, and I'm not an engineer or a legal person, so I want to make it really simple. You use AI every day already, all of these actually. So let me just give you the real story on this. AI, if you go and you type a sentence in your email and the sentence says your word is spelled wrong, and you might use the grammar differently, that's a computer giving you suggestions to improve how you're writing. Does that make sense? Second, machine learning. What's machine learning? It's looking at patterns. So for example, in organ donation, women are more likely to be living kidney donors than men. That's a pattern, a race pattern, right? But what if we add motivations? What if people who are more spiritual, who want to leave a legacy are more likely? What if people who live in different geographic areas are more likely to be donors? We are building understanding of patterns. That's what machine learning can do. And finally, generative AI. Generative AI is what you use on your phone every day when you're looking for restaurant reviews. And you say, what's the best steak restaurant in Fort Worth to go with my buddies here at this conference? And it goes, and it says, after looking at all these sites, the top 3 recommended steak houses are these. This is AI used in your life now, okay? And I want to say that because you've got to be powerful and take the weird words and the legal words and all that out of it, okay? But now I want to move it into your healthcare. So this is what everybody's afraid of. How could AI harm me or make the healthcare I receive worse, right? So the big fears I've heard are, what if AI and machine-led healthcare is robotic or uncaring? What if I want to talk to a real human expert? Can I trust it? Could it harm me in some way if it makes the wrong assumptions? It doesn't know what the clinicians know, right? These are valid, okay? And so what I want to say is, at the clinical level, this is what leaders in the American Society of Nephrology, this is what transplant centers and nephrology groups are trying to really look at to make sure that what's coming out of AI doesn't harm you. The other part is, we're really in a part of what they call disruptive healthcare, where we are changing how healthcare is done. We can look at that as being exciting or terrifying. And on any given day, it's valid that you might feel one or both of these things. My approach as a patient engagement expert is we are not fully doing everything that we can do for our patients. There are moments in your healthcare, I would assert, from my experience, that there wasn't someone there to listen to you, that there wasn't a quick response of an outcome, that you didn't get tailored information about care that may help you particularly, or your drugs would work the best for your body. If AI can help with that, I'm all for it. So what we did at the ASN is we said, okay, let's look at how AI and generative AI, meaning the chatbot kind of approach with, looking for your steakhouse, could affect care in these 5 different areas. And so I want to say also, I'm one of you more than I'm one of the guy that spoke before me. I am living the day-to-day life with patients. And so to listen on this group was profound. We have a paper coming out that I'd recommend that the AAKP review with everybody, because we really looked at how this could, I'm looking at what you have up here. Hold on. What we have. So I want to just talk about what we have found then on the recommendations. So the key that I want to say is that, let me see what we're showing. Sorry, I'm looking at what we have some slides missing here. But I can kind of recount some things that are missing just for sake of time. What I want to say is that what we're doing very simply is we are, let me go here to, just to speak a little bit. So what I want to say is, what are the recommendations? So the first part is how your care can be better, okay? So the first part I want to say is that what are areas, let me go back here. What are areas with CKD, AKI, dialysis, rare kidney, transplantation, where you yourself needed work to go better for you? So the first thing is that we talk about how with CKD, we want to diagnose people who are at risk of their kidneys failing as early as possible. So if you think about when you found out personally where you had kidney disease, did you get the medications you needed? Did they tell you how to prevent your kidney from failing? And what if we could go more upstream earlier? Second, I want to say that the people that are on dialysis, we're looking at things like anemia. So what are we doing where we can prevent anemia? We can have people not have to deal with that anymore. What are unique individualized therapies that we can do to avoid that? For transplant, it's interesting. We have people that there are organs that we're not able to find people to match to use. How could we find organs that very quickly we say, this organ would be very beneficial for this person in their community, and how do we get those to them? And then if you talk about chatbots, then you think, okay, what kind of information do we need to share with each of these communities? So with transplant, it might be, well, what are my options for transplant and what's best for me? For living donors in our community, the thought is, would I ever be a living donor? And then also for people who are facing for the first time that their kidneys are failing, what do I need to be doing to prevent them? All of that can be systematized. And that to me is very exciting. And that's kind of the stake of the recommendations. So, okay, sorry, maybe this is, am I going, oh, I apologize on the slides, hold on. Okay, so I want to give a real life example just because for sake of time, because I think when we talk about these rules, it's easier to see the excitement of it when you go deep. Okay, so here are some early test cases of how we can use AI to benefit patients. So first, we can learn from big data quickly. We can read biopsies more accurately. We can identify patients earlier who need better support and medical care, and we can build AI tools. So this is, to me, an example of what I think is very exciting. So right now, we know people who move forward for transplant and what they're concerned about because they come to transplant centers and tell us, right? What about the people that we never see? So you can now go to these public areas of data where you have people who are talking to anonymous people or on forums, and they say, you know what, I'm really scared about getting a transplant. Or I don't know if I'd be a donor because of this concern. And we'll never meet them in our healthcare setting, right? but we can really listen respectfully about what they're concerned about. So we went actually into Twitter, Reddit, New York Times, and YouTube. We pulled 203,000 people talking and having different things, and they talked about their financial concerns. And this is an example of one area that, like, look how we at AAKP or ASN could go in and say, look, these are the kind of things people are saying out in the community. Are we doing a really good job to answer their questions about financial concerns about transplant? So for the first time, we can hear them, and that excites me. The other part, they talk about big data. And so what's big data? I didn't understand this either. So basically, when you go into your hospital or your medical encounter, you have a lot of medical data available for you. So does everybody else. We also have the ability to link that with data from the community in which you live. So things like what neighborhood you live in, and if people in that neighborhood have a car. You also have lots of other databases that can merge. So people across the country, whether it's databases in dialysis or databases in transplant or databases anywhere, are able to build large databases and predict things. So what I want to say is, what does predicting mean? That sounds kind of scary. It actually detects people in better need for healthcare earlier. So in the case of this study here, this is using machine learning, looking for patterns. And what we found was that people who fit these characteristics were more likely to come in for a transplant, but not make it through to the end. So how could we do better by these people is the question. So now another piece I want to show you is biopsies. And somebody's going to be speaking about this later, but this is very exciting for you as well, because the biopsies are something, if you're saying how much kidney disease do you have? Have the person's kidneys failed? Doctors are seeing this with their eyes, and they're having a very expert opinion. But doctors' eyes can vary. If you use a computer, wonder if you could get more precise and earlier and look at more of these biopsies more quickly to really detect people in need of kidney interventions. That's AI. Now, the other part I want to say is I said this before, but we really want to intervene earlier with people who have this disease to not have it progress. That would be, to me, the most important value of AI in our field. And what I want to say is they've now built models that can help us understand earlier people in need of interventions. And so we want people to avoid dialysis, avoid transplants, slow or halt kidney progression, and reduce cardiovascular risk. This is an example of a machine learning model's findings, where the takeaway is that this model can predict decline of your kidney while you're at the beginning of it with some kidney function. So what's exciting here is, instead of saying, oh no, I hope your kidney doesn't fail, we can say, okay, we can predict what's going to happen, and we need to activate interventions upstream as fast as we can. So let me just get to the end. So here's what I think. We talked about how we can make sure that this is safe. So this is what I'm really passionate about right now. I think we do not yet know where we need AI and where we need a human expert for patients. This is something that I think there needs to be a lot of dialogue on. And what I would recommend, and this is me, this is not the ASN, is that we build compassionate human technology co-care models of healthcare. So if you look to the right, the MDs, you go to meet with an MD and they talk to you and they put your data into a computer. And then you also might go home and have, a peer mentoring conversation, or you might have a device on your arm that is helping detect, how well your medical outcomes are. But then you might talk to a chatbot. What if all of those can work together? So now there are times where you could text a chatbot a question in the middle of the night. Or you could call and the chatbot could then refer to your doctor to follow up, because the chatbot couldn't answer it. And then the device is tracking various medication and outcome and fever. You can now track fever at home. It's amazing what can happen. So the key that we're in, the point right now, is that we have new AI and devices, and we have to integrate them with the healthcare that we've known before. And how can patient communities help us? You're essential, because we need to say, What do you think of this device? What do you think of using a chatbot? Would you ever use it? What would make it helpful for you? What scares you? What kind of training do we need? And my job is incredibly interesting and busy right now because the integration of a compassionate human technology co-care model, well, is what can really improve kidney care. The last part, we talked about chatbots, so they can be a little scary. So I want to show you an example, and this is what's interesting. So I was like, well, is a chatbot as good as me? I'm a psychologist and an educator, let's take it personally. What if it's as, you need me, right? Every time. So we built a chatbot, and this is the piece I didn't understand because I work now with engineers. Chatbots create a set of content, educational content that's vetted and approved. It's not the whole universe of what's on the internet. So medically, the content at the base has to be approved by somebody. So we built this, we connected it to information, and it says, and this is about living donation, but all I wrote was, I'm scared to donate, right? You didn't say, could you give me any of the stats and the things? And what the chatbot now can say, and this is about the work that needs to be done to make sure this is compassionate and helps patients. I completely understand that feeling scared about the prospect of kidney donation is a natural response. It's a significant decision, and it's okay to have fears and concerns about it. Could you share a bit more about what's specifically making you feel scared? So as somebody starts engaging, whatever, you don't have to make it formal. You can just be talking to someone, right? And then over here, the other part is we have a lot of community members that validly don't know if they should donate their organs when they pass away. So I said, well, if I died and donated my organs, how do I know my organs will help someone, right? And all of a sudden, these are the kind of responses we get. We now need to vet what's coming out. We can modify how conversation is perceived. But to take home, here's what I want to say. AI and human co-care enhances the patient experience, outcomes, and donation rates. Technology supports, not replaces compassionate care, and there are many opportunities to expand AI integration across workflows in all health areas. Thank you.
So thank you, Dr. Waterman, for that. That was just amazing. And we have a couple of questions I'd like to pose. First, what is the best steakhouse in Fort Worth?
Hold on. Yes, someone down there, look, while we're talking. It takes about 3 seconds to get recommendations. Yeah.
Wonderful. So AI tools are developing rapidly, but adoption in clinical settings can be slow. So from your perspective, what needs to happen, whether it's more research, better regulation, or clinical education, to make sure AI improves patient care safely and effectively?
Yeah. So what I think now is we've been hearing the words now for 2 years in the public, right? We need to get really practical, I would say, and what I think our field most needs is for patients to prioritize the types of different approaches that would make the most difference immediately. So I think that there are a lot of, if we could build a chatbot, what would you like it to focus on? And if we could build a tool to regulate your medications, how would you like it to look and feel? I think that those decisions have to come from the lived experience of people of all ages and races and languages that can say, this would really help. And then the developers then need to go and do this and make sure it's clinically accurate and bring it back to you. And I think that process repeated in every area of kidney disease and transplant could make a tremendous difference. I also think on our side, we need to look at patterns at a very big level to get very precise so we can find the patients most in need of care earlier and move upstream.
Wonderful. Thank you. So this concludes today's session. And thank you again, Dr. Waterman, for being here, and to all of our speakers and for all of your thoughtful engagement.